The monitor is alarming, showing a blood pressure of 90/50. The patient is restless, their skin is cool and mottled, and their condition is visibly deteriorating. This is the onset of shock. I've spent my career in the ICU, and I know the distance between a textbook definition and a crashing patient can feel like a mile. My mission is to help you bridge that gap. To join our community of clinicians, make sure to subscribe and visit our educational platform. All the links you need are in the description. Moving from an overwhelmed novice to an expert starts with a shift in perspective. Shock isn't just a set of bad numbers on a screen. It is a mechanical failure in the body's plumbing. Hemodynamics is often treated as a complex mystery, but it is simply the physical study of how blood moves through the body. To solve a hemodynamic crisis, we use the NCSBN Clinical Judgment Measurement Model. This 6-step path provides a mental structure to move from initial observation to a confirmed outcome. This model provides a checklist for the mind. By filtering the mechanics of the heart through these 6 steps, a nurse can categorize information and isolate exactly which part of the system is failing. Using this structured approach prevents a nurse from reacting to individual alarms and instead directs their attention to the root cause of the physiological collapse. Step 1 is recognizing cues. You look for indicators of poor perfusion, like a capillary refill time that takes longer than 3 seconds, or a urine output that has dropped below 0.5 milliliter per kilogram per hour. Step 2, analyze preload. This is the volume stretching the tank before contraction. Per the Frank-Starling law, more stretch means a more forceful contraction. But overfilling beyond the elastic limit causes the pump to fail, pushing fluid backward. The second pillar is afterload. This is the resistance the heart must overcome to push blood into the body. Imagine the heart trying to pump through vessels that are tightly clamped down. The final pillar is contractility, which is the inherent strength of the heart's muscular squeeze, independent of the volume inside or the resistance outside. By assessing these 3 pillars, a nurse can begin to differentiate whether the patient is dealing with an empty tank, a broken pump, or a problem with the pipes themselves. Moving into steps 3 and 4, we prioritize our hypothesis. Given the soft blood pressure and low urine output, our clues point to an empty tank or hypovolemic crisis. The solution is to increase preload by administering a rapid fluid bolus. We aim to stretch those cardiac fibers back to an optimal length and restore stroke volume. Step 5 is to take action. We implement the intervention, carefully monitoring the infusion as the fluid enters the circulation to correct the volume deficit. This intervention isn't a guess. It's a deliberate manipulation of the heart's cellular mechanics based on the data we analyzed. The final step is to evaluate the outcome. We look for the physiological signs of recovery. The blood pressure begins to climb, and the kidneys respond with an increase in urine output. When a nurse uses this framework, the chaos of the bedside begins to clarify. The focus shifts from the noise of the alarms to a logical series of physiological corrections. Success in hemodynamics comes down to managing the relationship between the stretch of preload, the resistance of afterload, and the squeeze of contractility. Pairing these physical mechanics with a structured judgment model provides a roadmap to stabilize a patient in shock. This integration of knowledge and reasoning is how you provide high-quality care when every second counts. If you found this helpful, please like the video, leave a comment with your thoughts, and I'll see you in the next one.